Hi, my name is Hern. I'm an emergency physician and the medical director for EMS Bridge. Today, I'm going to talk to you for a few minutes about this really cool program where EMS is using buprenorphine for patients who have an opioid use disorder. I'm also going to be joined by Dr. Alicia Gonzalez. She's the clinical training director and one of the implementation leads for Bridge. So today, we're going to talk about a few things. But first I have to say that we are a program that is sponsored by the Public Health Institute, and we also have some funding from the CareStar Foundation for this project. Today, we're going to talk about the opioid crisis, a little bit about opioid use disorder and treatment, and specifically about EMS using buprenorphine in the field to help patients. Take it away, Alicia.
Hi, I'm Alicia Gonzalez, emergency physician and the clinical training director for the California Bridge program. And I'm here today to give you just the briefest overview of opioid use disorder and, more importantly, medication for addiction treatment. Unfortunately, we are all way too familiar with this graph that shows the tremendous increase in the number of opioid associated deaths since 1999. In fact, in 2021, in the US, we had a record breaking over 100,000 deaths from opioids. That was more than the car accidents and gun victims that year combined. These are not the kind of records that we want to be setting, and we've got to do something about it. How did we even get here? That's a very long story. But the gist of it is, back in the 1980s and 90s, we were really focused, a big push in medicine, on getting rid of all pain. And at the same time, Big Pharma was coming out with these newfangled medicines like oxycodone, which they said were extremely safe and not dangerous and should be used widely for all of our patients. So we sort of set this expectation that anybody with pain would get opioids. Simultaneously, there's a significant increase in the amount of heroin coming across the border from Mexico. And of course, our patients then and now have had limited access to care, behavioral health or otherwise, and in more recent years have had more struggles in the economic and emotional portions of their life than ever before. You put that all together, you've got yourself a perfect recipe for the US opioid epidemic. Thankfully, the neurocognitive research out there has shown us unequivocally that addiction is a chronic medical disease. It is not a moral failing. It's not bad people. They're just regular people who, yeah, maybe made unfortunate choices and started using drugs and developed addiction. But just like any other chronic medical illness, diabetes, obesity, high blood pressure, cholesterol, there are a lot of diseases that are the results of our choices. And that does not stop us from helping provide evidence based treatment, medication to help with these chronic diseases. Why medication for opioids? Because if you use opioids regularly over time, ultimately your body builds tolerance. It needs more of it to feel the same way, but in the end, develops dependence, meaning it requires some opioid to be present in your system to even feel normal. Without it, you enter withdrawal. And opioid withdrawal is miserable, super painful, brain on fire, vomiting, diarrhea, like horrific experience. And so you have to have a little bit of opioid for your brain chemistry to normalize and for you to just feel normal. But not only does medication make you feel better, it literally saves lives. If you look at the average rate of death, say your risk is 1, somebody who's using illicit opioids like fentanyl, their risk of death is 6 times higher. But if you start that same patient on buprenorphine or methadone as medication for addiction treatment, their risk of death approaches that of the regular population. This is a massive reduction in mortality, and it makes MAT for opioid use disorder one of the most effective and safe things that we can do for our patients. For us in the emergency department and in the EMS system, we know patients who have just overdosed and who required naloxone to come back to life are actually at their most vulnerable point. Their risk of death is highest in the next 24 to 48 hours, which gives us a very special moment and opportunity to help intervene and save that life when they are most vulnerable and at risk. You'll notice I said just start medication, start treatment, not fill out a bunch of paperwork, go to a specialty clinic, do a urine tox screen, et cetera, et cetera, et cetera. No, there are currently a lot of barriers built into the system, but our job is to lower the barrier to entry, to get rid of all these nonsense requirements and just start patients on medicine. Medicine that helps with cravings and withdrawal and prevents overdose. And there are multiple options, but we like to use buprenorphine for a couple of practical reasons. In our setting, buprenorphine is an oral medication that gets absorbed in the mouth. Don't swallow it because it gets absorbed differently. So, orally absorbed. And once the buprenorphine is in your system, it is a partial mu agonist. That means it partway turns on the opioid receptor. This does not cause euphoria and high the same way that a full agonist like methadone or heroin or fentanyl will, but it does take away cravings and it takes away withdrawal symptoms. It helps normalize the brain chemistry so someone can just live their life. Things we love about buprenorphine include the fact that it has a ceiling for respiratory depression. There's no ceiling on the dose. You can go up, 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 up on buprenorphine, but it won't cause overdose all by itself, the same way methadone or other medications can. So that makes it really safe. It's also got a really long half-life, so it can be taken as once or twice a day dosing. Very practical. Patients can go home with a prescription. They don't have to go every day to a clinic. And so for all these reasons and more, we like buprenorphine as a practical solution for us. It's safe in pregnancy and breastfeeding. You don't have to be in the hospital to start it. Patients can self-start on buprenorphine with good instructions, or a medic can help them start it too. You don't have to have a doctor there. It's safe for minors. Just make sure you know the consent rules for treatment in your local community. And if somebody's on buprenorphine, they need to stay on their buprenorphine, even if they're going to enter some kind of pain. So if they have like a broken leg, yes, you can add acetaminophen, NSAIDs, fentanyl, et cetera, but you got to keep the bup on board. Patients are often on buprenorphine for a really long time. Remember, we're treating a chronic disease here. It's not a treat and treat problem. So patients can be on buprenorphine their whole life, the same way somebody might be on insulin their whole life. And we should not be pushing people to stop taking their medication. As far as diversion, we're not as worried about that. Most patients who are looking for buprenorphine on the street are actually trying to be in treatment. If they wanted to get high, they would just buy fentanyl, which is cheaper and easier to find. But if we can lower access, make it easier to access buprenorphine from us, from the medical channels, then diversion won't be as much of an issue anyway. Not all patients are going to want to start treatment, and that's okay. We can still talk to them about harm reduction, not using drugs alone, and give them naloxone. We want to put it in the hands of every single person out there. It's like the AED or CPR of our generation. The more naloxone's in the community, the more equipped somebody can be to help in the event that somebody near them does overdose. We are definitely sick and tired of our friends and family and community members and patients dying from opioids. So our goal together is to make sure that we treat addiction like a chronic, treatable medical disease, that we put evidence-based buprenorphine, MAT, in the hands of our patients, and that we work together to decrease stigma and increase access to care. Welcome to the new standard of care, which is MAT for opioid use disorder. And I want to personally thank you for everything I know you will do to help us save lives.
Thank you, Dr. Gonzalez. That was fantastic. I really appreciate that overview and the perspectives that you bring about this incredibly important public health crisis. We're now going to talk to you, emergency department providers, about what EMS is doing for these patients. So EMS has started to give buprenorphine in a select number of these cases, in a select number of patients. And what I want to do is talk to you about how that is happening, what the protocol is, and how it aligns with the emergency department model for California Bridge. Once again, my name is Gene Hern, and I'm the medical director for EMS Bridge. So how did we get here? So a number of years ago, probably 4 or 5 years ago, we started exploring the option of giving buprenorphine in the field and the data behind that. So this actually comes from the work out of New Jersey, Camden, New Jersey. Jerry Carroll is the EMS director out there, and they had a protocol that allowed paramedics to give buprenorphine post-overdose after receiving naloxone. So they were sent into withdrawal symptoms from naloxone. So what we did is we took that protocol and we expanded it. And so what we're doing now is we are allowing paramedics in many EMS agencies across the state of California, and we've influenced a lot of protocol development around the country, to give buprenorphine for patients who are experiencing withdrawal symptoms from one of two ways. One is they're post-overdose and they got naloxone, and the other is they're in pure abstinence withdrawal. They haven't had any narcotics for a few days, and they are feeling those symptoms. So we started the protocol in Contra Costa County, and we published our results. And it turns out that about a quarter of patients who get buprenorphine in the field are still in treatment at 30 days, which is a long-term mortality difference of basically 2/3. So 65–70% of patients who are in long-term treatment at 30 days or in long-term treatment have a decreased mortality. decreased mortality rate of 2/3, which is remarkable. So the other thing we did is we talked about the concept of an overdose receiving center. Now, your hospital may be a bridge site, which is what we're calling it now, but we initially proposed this idea of, if this is the greatest public health crisis facing our country right now, why not have a specialized center where the staff are comfortable using buprenorphine, they have the resources, the pharmacists are all on board to get these patients into treatment quickly and regularly. So that concept of an overdose receiving center was like a trauma center or a stroke center or a STEMI center, but focused on patients who are at, honestly, a high risk of dying. In fact, basically the same risk of dying in the first year as a STEMI patient, so a 10 or 11% risk of death after overdose, which is remarkable. And then we also know that a patient, if they are not transported after getting naloxone, they have a much higher risk of subsequent non-fatal overdose. So that's pretty obvious, but that has also been documented. So in the next couple of minutes, I'm just going to run you through the protocols. Again, this is very similar to the ED provider quick start guide that has been out there for many years from California Bridge. But this is the EMS focus protocol, so we're going to talk about that and how it has changed recently. We updated it in the last couple of months as of early 2024. So we have the paramedics assess for opioid withdrawal signs and symptoms. And like the ED quick start, you have to have 2 or more objective signs. And of course, we all know the objective signs of opioid withdrawal. However, yawning, rhinorrhea, lacrimation are somehow more specific than anything else. So it's really, that's why I wanted to put those first and have the paramedics look at that. But again, you need 2 or more of the objective signs to have the patient enter the protocol. We also know the subjective signs: nausea, body aches, hot and cold, congestion. We also know that if you have a really bad case of gastroenteritis, you could probably hit a bunch of these boxes. We then have the medics assess for exclusion criteria. And this is how our criteria has changed in the last couple of months. We have them obviously look for the opioid withdrawal signs and symptoms. They have to have an opioid use disorder. They can't just have been at a party, took a white substance, and woke up with a bunch of paramedics around them and saying that they don't use fentanyl or narcotics on a regular basis. That is not what this protocol is geared towards. It is geared towards patients with a longstanding opioid use disorder. We've lowered the age down to 16. California law now allows patients 16 and above to get buprenorphine without parental consent. So the paramedics can do that if they encounter a 16-year-old or higher. Any methadone within the last 10 days, because remember, methadone is a long-term agonist on those receptors. You give them buprenorphine, you can actually make their withdrawal worse. It's called precipitated withdrawal. We've all heard of it. It is pretty rare in this setting. In the EMS setting, we see it about 1% of the time, but it is there. We need to be aware of it. Also, the paramedics look for any other severe medical illness, altered mental status, unable to give consent, etc. We have them do a COW score, and their score has to be 8 or above. This also aligns with the ED Quick Start Guide put out by California Bridge. Obviously, EMS Bridge is a division of California Bridge. We had used a COW score of 7, which is what the EMS protocols were based on, but we decided that it's best to align it with the ED Quick Start, which you may be familiar with as well. Obviously, if they have any exclusions or their COW score is low, they are not eligible. Obviously, the COW score, I'm sure you're familiar with, but it's the method for us as clinicians to evaluate the level of severity of a patient's opioid withdrawal. And then if they have a COW score of 8 or greater, they can be offered buprenorphine. And they can be offered buprenorphine without physician contact. That has also been recently changed and approved by the state scope of practice committee for paramedics. If the case is complicated, they may call base hospital for further guidance, or if it's complex or an additional support, and that is also very reasonable. If the patient meets criteria and the patient agrees to treatment, then they can administer buprenorphine. We use the films, 2 sublingual buprenorphine and naloxone. Technically, they're the Suboxone films. They just absorb faster. They get 2 of those and a reassessment after 10 minutes, and they can get a 3rd if their symptoms persist. Obviously, if everything's going well and all the symptoms improve, the paramedic is hopefully going to document the patient contact information. We request 2 follow-up phone numbers for our navigators to reach out to the patients, or for the navigators at your hospital to reach out to the patients. Providing leave behind naloxone, repeat and document a second COW score to show the improvement. The vast majority of our patients who have received buprenorphine have had improvement of about 7 points on the COW scale, which is pretty remarkable. We also recommend treatment to a bridge hospital if there's a bridge hospital in the LEMSA, in the EMS agency, county. If there's not, obviously, any hospital or patient preference. And then if the patient declines transport, inform them that a navigator still can reach out to the patient to provide them with a prescription, a follow-up appointment, or other navigational resources. These are our guidelines. You can find them at bridgetotreatment.org or emsbridge.org. QR code this and pull it up. Again, I want to thank you for your time and thank you for being accommodating and welcoming the paramedics to your hospital, especially ones who have decided to treat these patients who are at some of the highest risks of death in the next year with the literally standard of care of treatment. So again, thank you for considering buprenorphine in these patients, and thank you for all of your help in treating this public health crisis. I'm Gene Hern. Thank you for your time.